Joost Daemen, Mike Gibson, and we're talking about the use of QCA to measure FFR and its use in practice and trials. Joost, talk to us about what you did.
Yeah, so what we did is we performed a large-scale international randomized controlled trial assessing the non-inferiority of VFFR, being a angiography-based FFR platform developed by Medical in Maastricht, to assess its non-inferiority to FFR in terms of deciding coronary revascularization in patients with intermediate coronary artery disease.
Tell me about the size of the trial, what you did, and then what you found.
Yeah, so the trial was actually powered on 2,228 patients based on the event rates that we anticipated to be 6.5% in both arms, and with a non-inferiority margin of 3%, a power of 80%, and an alpha of 2.5%. We anticipated the need to enroll 2,228 patients, one-to-one randomized to either VFFR or FFR. So that's actually what we did between November 2021 and May 2024. We randomized those patients in 37 sites across 7 European countries and followed them up for 1 year for a primary composite endpoint of all-cause death, NEMI, or any unplanned repeat revascularization.
I just want to make sure this FFR that you're comparing to was a wire-based FFR. Is that right?
Yes, that's correct. So this is the comparator arm is conventional pressure wire-based physiology using invasive or intravenous adenosine.
Yep. And what do you find?
Yeah, so when we followed the patients for 1 year, we found an event rate of this composite primary endpoint of any death, any MI, or any revascularization of 7.5% in the FFR arm, and a event rate of 7.5% as well in the VFFR guided arm. So with that, we met the non-inferiority margin of 3%, and were able to conclude the non-inferiority of VFFR as compared to FFR with a P for non-inferiority of 0.004.
What were some of the advantages of the QCA approach?
Yeah, so what we found at first is that the use of the platform, which we validated offline in a series of studies in the past 8 years, which proved to have a very high diagnostic accuracy as compared to FFR, in the core lab or by independent investigators. But now this was the Fast-3 trial was actually the first trial to really assess the feasibility of using this platform in a real-world clinical practice in which the technology had to be used online, immediately on-site by local investigators to guide and to decide on a revascularization strategy. And that was actually quite interesting because what we found is that if you do conventional pressure wire-based physiology, you are able to complete the physiological assessment for all lesions per randomization in the trial for 99% of the patients. And in the VFFR arm, that was 96.5% of all cases. So that, I think, attests to the feasibility of the platform in terms of clinical use. So that was finding number one. The second thing
You
is
don't
that
have to instrument all three arteries to do that.
exactly. So with routine coronary angiograms, you can get your online physiology of basically all vessels just with two angiographic projection. The system makes a 3D reconstruction of the coronary artery, and the only boundary inlet condition that is needed is the aortic root pressure that is entered into the system as a boundary inlet condition. And with that, the system calculates your VFFR index within a matter of a second. So that's extremely fast, and that also translated into procedure times. So when comparing patients that underwent PCI, we found that the the average procedure time was 55 minutes in the VFFR guided arm versus 60 minutes in the FFR guided arm. So somewhat lower procedure times in patients that underwent the angiography guided physiology approach versus the conventional pressure wire based approach.
Have you done a health economic analysis? I mean, here you have to use a wire, you have to use adenosine, you have 5 minutes of extra procedural time. What could be the
Yeah.
economic savings of using an angiographic approach?
Yeah, so that's a very good question, and that's something that is obviously predefined within the study protocol, and that is something that will be performed within the upcoming months by a dedicated health economical team. Um, and that's quite interesting if you anticipate the results, because if you just say, well, the procedures are somewhat shorter, that immediately implies that if the outcome is the same, that the technology could per definition be more cost economical. But what we didn't talk about is the fact that if you do a angio-based assessment, the likelihood of finding positive lesions is somewhat higher. And in terms of numbers, the number of patients that actually underwent revascularization was 9% higher in the VFFR guided arm as compared to the control arm, a finding that was also found within Favor-3 Europe. So that's quite an interesting finding, because that apparently did not translate into differences in the primary endpoint, but may affect the cost economical implications of the angio-based technique. So this is something I think that we have to dig into and see how that at the end will impact the economical let's say results.
Well, obviously, a big fan of QCA here, having done it since 1987,
Hmm.
and a big fan of looking at flow, having invented the frame counting, putting all that together to make these measurements. This is always my dream. So glad that you guys at Pi Medical are making it
Hmm.
come true. Congratulations. Great job.
Thank you very much.
And thanks to all of you for joining us here live from ACC 2026.